Hello friends, welcome back to my channel Medicine on Zero. Today we'll talk about from the aspect of cardiology. Okay. In these cases, we'll talk about basically the ECG changes within the hyperkalemia and hypokalemia. So what is the topic for today? That ECG changes within hyperkalemia and hypokalemia. So let's write down the topic. So ECG changes in hyperkalemia and hypokalemia. Okay. So first of all, we need to know what is the normal potassium level. What is the normal potassium level? Now, the normal potassium level how much? That is around 3.5 to 5.5 milliequivalent per liter. Okay. So I'm writing it over here 3.5 to 5.5 milliequivalent per liter. Okay. Now if we get the values more than 5.5, it will be regarded as hyperkalemia. If we get the value less than 3.5, it will be regarded as what? Hypokalemia. So if we get the value, potassium value more than 5.5 milliequivalent per liter, it is known as what? Hyperkalemia. It is hyperkalemia. Alright. And if we get the value potassium level less than 3.5 milliequivalent per liter, it will be regarded as hypokalemia. Now I am talking details about the ECG. Now, whatever the changes we will get within the ECG. Okay, now as far as the ECG is concerned, at first I will talk about hyperkalemia. So whatever the changes we will get within the ECG, whenever we will get to see the hyperkalemia. So let's write it over here, guys. So hyperkalemia. Okay. Now one thing we need to know that amplitude of the T wave is very important. Amplitude of T wave, that is proportionate to the potassium value. Okay. So in these cases, if we get that hyperpotassium, if we get that more concentrations or more than 5.5 milliequivalent per liter for the potassium level, that will be regarded as what? Hyperkalemia, right? So as the amplitude of the T wave is directly proportionate to the potassium value, so definitely in these cases we will get the tall T wave, or rather we can say that tall tended T wave. Okay. So I will write it over here. The first thing we will get within the ECG, tall tended T wave. Now see, normally what do you know? Normally that the vertical length of the T wave within the that limb leads will get more than how much? 5 millimeter, or sorry, 5 centimeter, and in this in terms of the chest rate will get more than 10 centimeter. Okay. Let me correct myself. So it the normally will get the length of the vertical length of the T wave more than 5 millimeter, not centimeter, sorry guys, and in terms of the what? Near equal to, we can write equals to 5 millimeter in terms of limb leads, and whenever we will get around 10 millimeter, it should be centimeter, where we will get in terms of the chest lead. So if you get 5 centimeter, the vertical length, vertical amplitude, you can say the T wave around 5 centimeter, that we will get where within the limb leads. And if you get the length of the T wave, vertical length of the T wave 10 centimeter, that we will get where within the chest rate. It's normal. But in these cases, the amplitude of the T wave, and as it's proportionate to the potassium value, so in these cases, in hyperkalemia state, we'll get the 12-10 T wave. Okay. Now next thing, in these cases, we'll get the ST segment elevation. We'll get the ST segment elevation. I'll draw the ECG, don't worry. ST segment elevation. A third important thing is over here. As we know that whenever we will get, the more potassium values. So what do we know? The potassium is responsible for the repolarizations. So that will overwhelm the what? The depolarizations. That's why in these cases we can get the amplitude of the P wave that will be less, or sometimes we can get also the P wave that is absent. P wave absent. So what did I say you? Why we'll get the P wave absent over here? What will normally that the potassium that is responsible for causing the repolarizations, but the P wave we will get when we will get the depolarizations. But if we get the more potassium value, that will overlap. We can say that depolarizations is, as a result we'll get the P wave that will be less over here, or you can get sometimes you can get the absence of the P wave, the amplitude of the P wave that will be less, or sometimes you can get also the P wave that will be absent. Now in which cases we can get the P wave absent? Let's write it over here. So I'm writing it over here that P wave absent will get the first thing as I talk about over here about the what? Hyperkalemia. So I'm writing it over here. Hyperkalemia. Second thing we can get in terms of, it's quite familiar for you, in atrial fibrillation. Atrial fibrillation, and we can also get in terms of the sinus 6 syndrome, or 6 sinus, you can remember, just like this. Okay. So let's write it over here in this way, that's 6 sinus syndrome. 6 sinus syndrome. Now, what did I say you? That we'll get the amplitude of the P wave in terms of the hyperkalemia, that will be less over here, or sometimes you can also get the P wave that will be absent in terms of hyperkalemia. Now the P wave absent where you can get in terms of the hyperkalemia, in terms of atrial fibrillation, also you can get in terms of the 6 sinus syndrome. Okay. Along with that, sometimes that if we just draw the ECG, or before that let me tell another interesting point over here, that in these cases we'll get the broad QRS complex, because see, when we were talking in terms of the hyperkalemia, that will cause the repolarization for longer durations. As a result we'll get, or rather you can say the heart that will be slower. Whenever we are getting the hyperkalemia, at that time that heart that will act slowly. As a result we'll get the broad QRS complex. Okay, so we get broad QRS complex. Okay. Apart from that, we'll get another thing is over here, that is sine wave pattern. Sine wave pattern. Now what is sine wave pattern? See, whenever we'll get the broad QRS complex that will merge directly with the T wave, as a result we can get this type of the finding that is known as sine wave pattern. Okay, so when you will get the sine wave pattern, you can write it over here, that when the broad, okay, let me write it over here clearly for you. So whenever we will get the broad QRS complex that will merge with T wave. Okay, as a result we can get the sine wave pattern. It's one of the most important questions as far as your different kinds of the entrance exam is concerned. Okay, so what are the findings we got over here? So whenever we will get the hyperkalemia, in terms of the hyperkalemia we will get first things, as I said, the amplitude of the T wave is directly proportional to the potassium values. As a result we will get the 12-10 T wave over here. Okay, now see, sometimes we just get a question just like this, that hyperacute tube. Now if in the examinations this question, this timing mentioned that hyperacute tube, basically we can get well in terms of the myocardial infarction. We will get in terms of myocardial infarction. Don't get confused. The hyperacute tube with protruded tube. Okay, it's totally a different thing over here. Okay. Now, if we just draw the ECG, what type of the ECG will get over here? Now, at first I will draw the normal ECG, then I will show you the pathological ECG over here. Now, let's try to draw the normal ECG, and we will draw the ECG where we will get the hyperkalemia. Now, as far as the normal ECG is concerned, as we know, simply we will get, okay, write it over here. So you can get the PA, or PA is absent, temperature of the PA will be less. Okay. And along with that we will also get the PR interval that will be prolonged. Okay, the PR interval that will be prolonged over here. Along with that we will get what? Broad QRS complex, and you get broad QRS complex, and that will directly merge with the tube. And as a result we can get the tall tinted tube. Tall tinted tube. Again you can get the tube, for example, just like this. Okay, now see what type of the changes we are getting over here. Now see what is the most important findings over here. In these cases we will get the what? Broad QRS complex. We will get broad QRS complex. Along with that, this S wave, broad QRS complex, that is directly merged with the T wave. Okay, that's why this type of the thing is known as what? As I said, sine wave pattern. So what do we mean by sine wave pattern? Sine wave pattern means whenever we will get the broad QRS complex that will merge directly with the T wave, this type of the finding is known as sine wave pattern. Okay. Now, in this case, see that height of the tube. See, sometimes the height of the tube in terms of the tall tinted tube, that will be greater than the R wave. See? So in these cases, height of the tube, in these cases we will get the height of the tube that will be greater than the R wave. Okay. So height of the tube that will be greater than the R wave. And one more thing, as I said before also, that if in the exam it is mentioned that hyperacute tube means that we have to understand in terms of the myocardial infarctions. Okay, myocardial infarction. Now these are the findings, and whenever we will get another important thing, whenever we will get the potassium value, okay, it's very important, more than 8 milli equivalent per liter, that will cause the diastolic arrest. And this is the most common cause for hyperkalemia that will lead to the death. Okay, so you can say over here, diastolic arrest. We will get diastolic arrest, and this diastolic arrest leads to the death. So the most important cause that can cause death in terms of the hyperkalemia, that is the diastolic arrest. Okay, diastolic arrest. Now we'll talk about the treatment. What are the treatment you can get over here? So what are the findings we got over here? At first, I am repeating once again. We will get the tall tinted tube. The length of the tube, vertical length of the tube, that will be greater than the R wave. The second thing we'll get over here, the ST segment elevation, and the third thing we'll get the the amplitude of the PU or the height of the PU, that will be less, or sometimes we can get the absence of the PU. And apart from the hyperkalemia, in 2 other cases we can get also the PU absence, where in terms of the atrial fibrillation and sick sinus syndrome. Okay. Now let's talk about the treatment. Now as far as the treatment is concerned, what other thing we can do over here? See, the first thing we can use the first line drug, or rather you can say the first line drug. The first line drug we can use over here, that injection of calcium gluconate. So the first line drug we can use the injection of calcium gluconate or calcium chloride. So see, what's the main region over here? See, normally what do we know? The calcium that will cause the contractions, and the potassium that will cause the depolarizations. Okay. Now see, whenever the calcium is causing the contraction, rather we can say that the depolarization, this calcium, more amount of the calcium that will antagonize with the potassium values. So what is the mechanism of action over here? We can say that more amount of the calcium gluconate, rather we can say calcium only over here, that will antagonize with the potassium values. So I can write it over here, that calcium antagonize with potassium values. Okay. The second thing, you can use the insulin drip. The second thing, we can use the insulin drip along with some dextrose. Especially if we talk in terms of the the pediatric cases, we have to use insulin drip along with some dextrose or glucose. Now, as you know that insulin, there is a relationship in between the potassium level and the serum potassium level and insulin level. Now, insulin that will always send the extra potassium, okay, within the cells. So what insulin it will do? Insulin that will send the potassium within the cells. So send potassium within the cell at the rate of 0.5 to 1 milliequivalent per liter. So milliequivalent per hour is the rate of sending of potassium from the blood within the cell. So first line drug we can use that what? If in the exam they are asking about what is the first line drug, okay, that should be the injection of the calcium gluconate or calcium chloride. And the most effective drug, if they ask which one is the most effective drug, that most effective drug, that will be the insulin drip along with dextrose in terms of the pediatric cases. The third line drugs, you can use the salbutamol nebulizer. Don't be surprised to hear that the salbutamol we are using in terms of hyperkalemia. As we know, the salbutamol we are using in terms of the COPD or respiratory distress syndrome or asthma, as we know. But in this case, see, what is the main thing is over here? Salbutamol nebulizer. What is the mechanism of action? The mechanism of action for this drug, that is salbutamol that can potentiate or that can activate the insulin. Now see, whenever the salbutamol that is able to activate the insulin, this insulin again that will send the extra potassium from the blood within the cell. Okay, rather you can say it's one of the side effects, okay, that can cause the hypoglycemia. Now, apart from that, okay, so what did us up to this much? That injection of the calcium gluconate, this is the first line drug, then the insulin drip, this is the most effective, okay, drug. The third, I said the salbutamol nebulizer over here, okay. And sometimes if you want to excrete out the, for example, the potassium, the concentration of the potassium within the blood is more. So another way we can do over here, we can excrete out the more potassium through the urine. That's why you can use the furosemide. So the loop diuretics we can use furosemide, because this furosemide that will cause the what? Kaliuria. That will cause the kaliuria. So what can we say over here? This furosemide that will cause the kaliuria. That will cause the excretion of the extra potassium through the urine. Okay. The most effective treatment, what will be over here? That will be the hemodialysis. The last thing is over here you can do hemodialysis. The hemodialysis By it we can just exchange the electrolytes. So this is the most effective treatment. This is the most effective treatment. Now in the exam, if they ask which of the following is the first line drug, that will be calcium gluconate, injection of the calcium gluconate or calcium chloride. If they ask which of the following is the most effective drug, is the first line drug, is the most effective drug, that then it will be insulin drill. And if they ask which of the following is the most effective treatment, okay, then it will be hemodialysis. Okay. Now, if we get an individual who is having chronic hyperkalemia, okay, let's write it over here. That is an individual who is having chronic hyperkalemia. So, chronic, if we get the chronic hyperkalemia, at that time, which of the following drug will be most appropriate drug? This question came in 2020 on FMG, so you can remember from here. That will be patyromar. So patyromar, that is a drug that is used to treat the chronic hyperkalemia. Okay, so that will be patyromar. Patyromar. Okay. Now this is all about the hyperkalemia. Now let's talk a few words about hypokalemia. What are the thing we'll get in terms of the hypokalemia? Okay. So as I said over here, one more thing that yes, here we'll get also the prolonged peer interval. Prolonged, we'll get the absence of the peer, along with that we'll get the peer prolongation. Okay, peer interval, that will be prolonged. Apart from that, we have to know right now about what? Hypokalemia. So we are not supposed to neglect the topic hypokalemia. That is also important as important as the hyperkalemia. So sometimes in the nowadays most of the questions are coming from hypokalemia. That's why you should pay attention over here. Now see, when we are talking in terms of the hypokalemia means the value that will be less than 3.3 milliequivalent per liter. Okay. As I said, the amplitude of the TF. See, in the first I already explained you guys that the amplitude of the TF, that is directly proportional to the potassium values. Now in terms of the hypokalemia, we'll get the potassium value that will be less. So definitely the the vertical length of the TF, that will be less also. Okay. So the vertical length of the TF, that will be less. Sometimes we can get also the absence of the TOF, and sometimes you can get also the inverted TOF. Now inverted TOF you already also read. You also read where? In terms of the myocardial infarction. In myocardial infarctions, in terms of the hyperkalemia, I already said you that hyperacute TOF. So hyperacute TOF is totally different from tented TOF. Okay. The second thing we'll get over here, the vertical length of the POF. See, whenever the potassium level that is going to decrease, as a result the contractions within the atrium, that will be much more with respect to hyperkalemia. That's why in these cases we'll get the POF, the length of the POF, that will be more over here. But the thing is over here that pure interval, that will be prolonged. This is the most important question I'm going to discuss right now. See, sometimes there is a chance to do the mistakes in the exam. In terms of the hyperkalemia, we also got the peer prolongations. In terms of hypokalemia, we will also get the peer prolongation. Don't think that we'll get the reverse thing. In terms of hyperkalemia, we got the peer prolongations. In terms of hypokalemia, we will also get the peer prolongation. Okay. In these cases, we got the ST segment elevations in hyperkalemia. So in hypokalemia, we will get the opposite one. So we will get the ST segment depression. Okay. And in this case, another thing, we will get the prominent E wave. We will get prominent E wave. We will get prominent E wave. Okay, prominent E wave. Okay, now let's draw the ECG. What type of the ECG we will get over here? Now, as far as the ECG is concerned, whatever the ECG you will get, so we'll get the PF that will be normal, or sometimes the length of the PF will be greater than the normal level. Then we'll get PR prolongation. Okay. Then we'll get the segment depression over here. Along with that, okay. See guys, what I am saying you, try to understand what I am saying you. It's very important in hypokalemia. Okay. Now, whenever I'm talking in terms of the hypokalemia, we'll get the POF, length of the PF that will be more, and along with that we'll get the PR interval. The PR interval that will be prolonged also. Okay. Apart from that, see. Okay, just like this. Apart from that, we will get the segment depression over here. We can get also the inverted TOF. So we'll get the inverted TOF and we'll get the prominent UF also. Now we are getting over here the segment depression. Okay. Now what we want to say you that, as you know, normally what do you know that in terms of the, in this case, see, in terms of the hypokalemia, we are getting the PF, the length of the PF, the vertical length of the PF, that is getting also increased. Now that is known as pseudo-pulmonal. Normally what do you know? Normally we know that in pulmonary artery hypertension, we can get also the what the vertical height of the PF that will be increased. But in terms of the hypokalemia, we can also get the vertical length of the PF that will be also greater over here. Okay, but that's why it is known as what? Pseudo-pulmonal. Pulmonal. Okay, with the absence of pulmonary artery hypertension. Now normally we know in terms of the pulmonary artery hypertension, okay, we get the P pulmonal, but in terms of the hypokalemia we will get the pseudo P pulmonal. That's why I wrote the words that with absence of pulmonary artery hypertension. Okay. Now let's go to the treatment. What are the treatment we should suggest for hypokalemic patients? Okay. Now, as far as the treatment is concerned of the hypokalemic patient, in these cases we have to with the supplementations of potassium chloride plus intravenous fluid that should be diluted. Diluted potassium chloride plus intravenous fluid. Whenever we are just using the fluid, definitely it will be diluted. Okay, so this is the treatment. Now apart from that, one more most important thing is over here. Okay, that if, as I said, in terms of the hyperkalemia, the most common cause that can leads to death, that is our diastolic arrest. So whenever we will get the potassium value more than 8 equivalent per liter, that will cause the diastolic arrest, that can cause the death. But in terms of hypokalemia, the most common cause of death, in terms of the hypokalemia, the most common cause of death, that is nothing but the diaphragm paralysis. So I am repeating once again that if in the exam it is asked that what is the most common cause that can cause death in terms of hyperkalemia, then it will be the diastolic cardiac arrest. But in terms of the hypokalemia, the most common cause that can cause the death, that is nothing but the diaphragm paralysis. Okay, hope it's clear now. This is all about in terms of the diagnosis, treatment, and the ECG pattern in terms of hyperkalemia and hypokalemia. Okay, in the next part I'll talk about multifocal atrial arrhythmia. Okay, where I'll talk also a few points related to potassium level. Okay, so that's all for today. See you in the next video soon, and please do subscribe my channel and share it, please. Thank you for watching.